Good afternoon. It's a real pleasure to be able to speak to you today on this, I think, very important topic, and one that's been in front of us now for several years, but I think hasn't quite translated into the clinical arena as well as it should. And that is embracing the prognostic value of molecular markers to inform thyroid nodule and thyroid cancer management. My disclosure is that I've been very involved in this space, both from a research standpoint and consulting standpoint over the last decade with many different companies. And here's what I'd like to talk through. I first want to look back at the last decade and acknowledge our ability to translate genomic understanding has been improving thyroid care, that we have figured out how to do this and have done it well through the process of utilizing molecular diagnostics. That has really taught us to acknowledge the power of individualizing care, that if we can provide the right care to the right patient at the right time, it will lead to a better outcome. But it is a long journey, and hopefully I'll be able to show that to you and prove that to you here. What I want to spend the bulk of my time doing is foreseeing the next decade, and in particular, talking to you about molecular prognostics and also their power ahead. As we start this talk on genomics and molecular medicine, I think the starting point as relates to thyroid nodules and cancer care is this: going back about 15 years, the discovery and then acknowledgement that a single gene, BRAF, and within it a single mutation, the V600E mutation, was the cause of about half of all papillary thyroid carcinoma. It was the driving event. It is the oncogenic cause, and this can be easily detected and identified. And I think this certainly led all of us to think, geez, if we just figured out half of the genomic causes to thyroid cancer, that perhaps our real search should be then looking for the other 50%, and we will have identified all of the molecular mechanisms underpinning thyroid cancer, and that will lead us then towards many different potential uses of either identifying those causes or not. But it's never quite that simple, and the complexity is really best described, I think, here with the second most common mutation in a single gene that was acknowledged through the Thyroid Cancer Gene Atlas, which is mutations in the gene RAS and its isoforms, the N, H, and K isoforms of RAS. Because this has shown us that single gene mutations actually don't always mean something is cancerous, and in fact, RAS mutations are found commonly in benign nodules as well. That's shown here by this meta-analysis really nicely, looking at nearly 60 high-quality studies using histology as the gold standard and finding that RAS-positive nodules are benign and tend to stay benign about half the time. This out of Martha Zeiger's group, and a very important, I think, initial study. And I like to often back it up with this, telling you and just describing my experience as well, which dates back now about a decade, when internal to the Brigham and Women's Hospital in Dana-Farber, they had launched a panel that was seeking to do whole exome sequencing, deep genetic sequencing on about 600 oncogenes, cancer-associated genes. We call it OncoPanel. There are probably parallel platforms you've heard about at numerous other academic institutions, but I quickly jumped on board and wanted to submit my 50-year-old male who had a 2-centimeter papillary carcinoma. I was very curious to understand what was the genetic driver, so I submitted the tissue. And this is reported back to me then, and the way OncoPanel is reported is with an analysis of differing tiers of findings. These are the 600 cancer-associated genes, and the report I first got back was to acknowledge that there was a tier, are there any tier 1 mutations? What does this mean? That means there's well-established evidence. It is the causative mutation. It is the driver event actually that is causing your thyroid cancer. And the answer was no, that none of those were identified. But then they often give you the next tier 2 mutations, and we were told that there was one. And what does this mean? Well, it means that there may be some utility here, that it seems associated potentially, but we're not exactly sure. And it was to my surprise that I was told then that the tier 2 variant was detected in my papillary carcinoma in the BRCA gene, the gene associated with breast and ovarian carcinoma. And I didn't really understand what was going on. So when I talked to my colleagues, they quickly explained that this was simply a variant in the gene that had no detriment to the function of the BRCA gene, nor did it cause your thyroid cancer in any way. If you will, it's just the diversity of genetic evolution that occurs, and you'll find thousands of these, but you can kind of ignore it. And in fact, I kept reading, and the tier 3 mutations from OncoPanel, where there may be some in vitro associations or animal models suggesting this could be part of a pathway. I found 4 more mutations, including in neurofibromatosis, the TP53 gene. But again, when I discussed it with my colleague, these really are not causative or active oncogenic mutations. They're really just variants that are innocent bystanders and have no harm. And so you can somewhat ignore them in relation to your papillary thyroid carcinoma story. And finally, to play it all out, they give you tier 4 mutations. Amongst those 600 cancer genes, there are another 20 or so that really we have no clue what they mean, probably nothing. But in total, that's about 30 different genetic mutations when you start looking in deep sequencing at the genes themselves. And really a wrong hypothesis, because if you look for mutations, you will find them, but most of them are completely meaningless, as was the case here in my papillary thyroid carcinoma. So that's really the background, but that really, I think, led our field and many of us to think more broadly. And the next step was to acknowledge this, that when you think about cellular biology and genomics within this venue, there are multiple big buckets of molecular targets. That in most cells in the body, DNA is transcribed to RNA, which is then translated into a functional protein that does the job of that organ or that cellular material. There is also this last inhibitory bucket of microRNAs, which inhibit that last step. And each of these early on had some investigation as to how they might translate into effective genomic markers of help for clinical care as relates to nodules and cancer. But I think what we're seeing forward, and certainly my opinion, is that RNA expression is proving to be the most impactful. As you think about how this impacts clinical care related to thyroid nodules and cancer, why is it that RNA expression is so valuable? Well, it dates in part back to about a decade ago when there were, for example, the ability on a chip like this to first look at the RNA expression of all 22,000 expressed genes in our genome. And some are upregulated, some are down expressed. You began to see these printouts like you see here of the red and the green. And while we use now a different technique, nonetheless, we get the same information. But the power here behind RNA expression is that you begin to look at thousands of genes together. You analyze their pathways, platforms, and you begin to understand how powerful this can be to see the integration of inflammation, growth, repair, benign and malignant processes. The other value is that you can continually iterate and improve. It gets better over time with the more data and more analysis you do. It may come as no surprise, therefore, that currently RNA expression is actually a crucial component to the current available set of all 3 different thyroid diagnostics available to us at the present time. And so again, my belief that RNA expression is really going to be the lead here. Now, as we translate this into clinical practice, I think the story continues with acknowledging the initial success of the diagnostic molecular story, really because that's where we first sought to improve clinical care, and we did. All of the diagnostic tests ultimately aligned on this process that we could identify amongst cytologically indeterminate samples who not to send to thyroid surgery, who didn't need it. And they were purposely designed, as I mentioned to you, all of them now exploiting RNA expression as a crucial part to the test and all maximizing their negative predictive value. And the best metric of whether they're making a difference is shown here in this variable called surgical yield, which is the idea that we should be sending patients to surgery to remove their thyroid cancer if they have thyroid cancer. Anyone that is going to surgery for benign disease would be hopefully what we'd like to avoid. And so what is that surgical yield? Are we doing well? And you can see since the onset or the implementation of these molecular diagnostics, we can find good data that has moved us in the 90s upward to the 2000s and to the current era where clearly our surgical yield is improving. Thanks to these tests. But the problem is that these diagnostic tests are not ideal at telling us the extent of surgery we should pursue, or they don't really tell us anything about whether we should administer radioactive iodine. They don't inform us of a follow-up strategy. They don't really prognosticate. And when you think about the application of molecular knowledge as it is applied to thyroid nodule and cancer care, there really are three buckets. I just walked you through how we are using it for diagnostic purposes. But equally important, we'll be thinking about it from a prognostic standpoint, or can genomics help to identify unique therapeutic targets for pharmaceutical intervention, especially for advanced disease? My take on the literature and available science is that we've done well in these 2 out of 3 buckets, certainly diagnostically, as I told you, and I think we're using it for these advanced cases to understand at times a focused mutation that we can treat. I don't think we've done a good job yet regarding the molecular knowledge translating into prognostic endpoints, and that's what I hope to be able to share with you here later in this talk. In fact, when you go back to our published American Thyroid Association guideline in 2016, the most active version on thyroid nodules and cancer care, Brian Haugen, the lead, myself, and many others part of that effort, we acknowledge that the ability to use molecular genomics for prognostication was simply not there yet. And it was in large part because guidelines at the time are working off of data that were published a few years before the final publication of the guideline, and we just didn't have the science yet to show us how to use it. But we knew it was coming, and indeed, I think it's here for us now. So why are prognostics important? What's the value added proposition? I think the answer goes something like this. If you go back to the 1950s and then for the next 50 years, arguably there was a standard treatment to all well-differentiated thyroid cancer, and that was that there should be thyroid surgery, in most cases radioactive iodine ablation, and then long-term TSH suppression. And the reason this kind of stuck as a standard, I think, is because most patients were cured. And even though there were no randomized controlled trials to ask if we needed all of this intervention, once you had a treatment strategy that seemed to be causing a cure, there was little reason to pull back from that. But that changed. In the last 10 years, we are asking those questions. We are really wondering, is that simply too blunt of an approach for a diverse disease like thyroid cancer? And indeed, are we over-treating many? Is there more harm then from that treatment than there at times is benefit? And it makes sense, right? If I were to put 2 cases in front of you and say, would you do a blanket similar approach to a 69-year-old female with a 1.9 centimeter follicular variant of papillary carcinoma and no lymph node disease in compared to a 38-year-old male with a 3.9 centimeter classical variant and extensive lymph node disease? You'd probably say, no, I'd think about them a little different in terms of risk, and I'd probably want to treat them a little differently. In fact, the current guidelines and I think current literature are now supporting a more nuanced approach that we certainly are asking, should we pursue thyroid surgery? And yes, we still want to seek a cure, but is it needed and how much is needed? Is a hemithyroidectomy perhaps favored? And thereafter, should we use radioiodine at all? And if so, at what doses and for what endpoint? And again, what's the degree and duration of TSH suppression? It is quite clear that we are much more than ever before individualizing our treatment. We are thinking more prognostically. So the question then arises, how do you translate molecular data into prognostic decisions? And I will argue to you, I think we're just starting to figure this out. We don't have all the answers, but we know it takes a lot of deep data and understanding and iterative analysis to really figure it out. The goal here is really to find the synergy, which means the mutual exclusivity of the different factors like clinical, radiologic, cytologic, and molecular, where they're all value added on top of the other. My belief, and hopefully I'll be able to show you why, is that RNA expression patterns are going to once again hold the greatest promise for leading us forward. I think the core starting point, as I'll show you, is that we already can embrace this wonderful paper, the Thyroid Cancer Gene Atlas, and the other available published scientific evidence. But beyond just the TCGA, it's important to note that that was a very homogeneous group of thyroid cancers that were analyzed. And indeed, thyroid cancer is very diverse. Think of some severe variants to papillary carcinoma compared to NIFT-P. That is a wide range of overall risk potentially. And it's not an all or none. As you'll hear me speak a little bit here, we still will be looking at times and find value in certain detections of unique DNA mutations. It's just that I think that's going to be a much smaller degree of power and potential in comparison to identifying these RNA expression patterns, which I think will be applicable to almost all clinical scenarios. Our goal is to move this from the bench to the bedside, and I think we can. We should evolve our staging systems, as I hopefully will be able to show you, embrace this idea of RAS-like, BRAF-like, and non-RAS, non-BRAF-like thyroid cancers for every patient, as we're looking for patterns that will help give us information. So we're just starting to figure this out. And what was one of the light bulbs that went off early on that were giving us clues that we should be thinking more prognostically and then moving towards kind of the molecular idea of fulfilling that prophecy? Well, one idea is well described in this manuscript. So we published this now 5 years ago when we started to kind of expand our mind to realize that thyroid cytology and the Bethesda classification system appeared to be telling us more than just what its first priority is often claimed to be, which is it tells you the percentage risk that a nodule, if it's indeterminate, may prove to be cancer. Bethesda 3 AUS plus may be a 25% risk that will prove cancerous. Well, yes, that's true. But when we looked here at about 1,300 consecutive malignancies that were detected over about 20 years and correlated that Bethesda cytology to histopathology. So the issue here is when it proved to be a cancer, then what type of cancer was it? You started to see some very interesting kind of prognostic steps forward. What I'm saying here is take that Bethesda 3 category, AUS plus. If it is going to be cancer, it is more likely than not going to also be a follicular variant of papillary carcinoma. And we know that that's more likely than not to also be driven by a RAS mutation. But that's not true if you're a Bethesda 5 or 6 suspicious or malignant. You're much more likely then to have a classical variant of papillary carcinoma, which is a BRAF positive cancer most of the time. And we would argue that Bethesda 4 is probably the most diverse, with numerous different malignancies, both high and low risk, that fall within this group. Nonetheless, the idea that the eyes that were opened, if you will, is that there was a beginning understanding that cytology could help predict cancer risk and prognosis, and could even begin to give you clues for the likely genetic profiles, but only very crudely. But that's where we're going with this, right? Continually, is that can we think about all of our different buckets of risk assessment that we're doing clinically, hoping to find the ones that are equally independent and therefore independently prognostic from each other, and bring them all together, whether it's our clinical demographic risk assessment, our radiologic risk assessment, our cytologic risk assessment, and our molecular risk assessment. And the answer is, I think we can, and let me give you my thoughts. I think the one area right here and now that we can pull into clinical practice that we really haven't done as well as we should stems from this paper, now 7 years old. This is the Thyroid Cancer Gene Atlas, a real tour de force, a wonderful manuscript for those who are leading this and part of it. This looked at about 300 pretty similar thyroid cancers, papillary thyroid carcinoma. But as we unpack it a little bit, one of the first findings is that they were able, the authors, to clearly give guidance that when you look at any population of papillary carcinomas, it divides itself based on expression signatures into kind of 3 big groups. It's that BRAF-like papillary carcinomas, RAS-like papillary carcinomas, and in between, kind of the non-BRAF, non-RAS-like carcinomas. That genomic data could provide this large prognostic grouping, and that mattered, and I'll show you why here upcoming. But I'll point out something else from the TCGA, which is here in the green boxes. You'll note that the RAS-like tumors, which are a big part of the papillary carcinoma family, they don't always have RAS mutations. And that is getting at this mutual exclusivity, that understanding the expression pattern seems to be equally additive to at times understanding the genomic single gene mutation. And that also plays itself out when you look at the histopathology, because we said that, well, most RAS-like lesions are going to be follicular carcinomas. Those are shown in red. That you'll also see that there are some blue areas even within this group. Those are classical variants of papillary thyroid carcinoma. And that's the idea, that the RAS-like expression, or conversely, the BRAF-like expression, can be very prognostic and synergistic over and above what we already know from cytology or the mutational status. That's very powerful. Well, and this paper, I think, is very telling as to why it's so impactful. This is by Tang and colleagues, now just published in the last year. It looked at the TCGA and one other publicly available database, found 676 genetic expression profiles, and really tried to correlate, well, what does that tell us a little bit? Now, notably, they were able to analyze 570. What that also tells us is that 15% are likely going to fall into yet another category that we need to still figure out. But nonetheless, there were BRAF-like cancers, RAS-like cancers, and non-BRAF, non-RAS-like malignancies. And go from left to right here, you can begin to see that these correlate very nicely then with extent of disease and prognostic features like lymph node metastases, gross extrathyroidal extension, extensive disease like N1B or T4 disease or distant Mets. That would be very useful to know preoperatively or before you give radioiodine, or when you think about how fast to see someone back and follow them for risk of recurrence. RNA expression patterns appeared to be very beneficial in that they predict risk that is validated through pathologic findings. But you may be asking, what about those single gene mutations? Do they not still provide any help like BRAF or RAS? Well, it's never an all or none game. And yes, there is potentially some utility here. And the classic example, though, to describe the answer, to tell the answer to that question is shown here. These are data by Mingzhao Jing, my colleague, who has led a lot of the effort here regarding initial understanding of BRAF positive disease. And what he showed, along with his team, is that if you had a papillary carcinoma that possessed that BRAF positive oncogenic driver, you were more likely to recur than someone who had a papillary carcinoma that was otherwise BRAF wild type. So yes, on a single univariate analysis, it was prognostic in that way. It turns out, however, that when you looked at it in conjunction with what you already knew from the histopathologic assessment, that it was not independently prognostic, that you already assumed that risk and knew that risk by understanding and looking at the histology itself. Nonetheless, there are examples as you move more and more into this that, let's say, you identify multiple single gene alterations. Well, then it improves the prognostic profile even more. In this case here, looking at two mutations in conjunction, the BRAF and the TERT mutations. And yes, you start to see prognostic information. Or here, if you combine three, in this case, BRAF, TERT, and RAS. So you can certainly find, and we certainly will continue into the future, I think, finding some value from single gene alterations. But I think it will pale in comparison to the broad application of these RNA expression patterns. And that's really shown here in this Tang article as well, which is they were able essentially to bucket many of these single gene mutations more broadly into these expression patterns. And you can begin to see how it's a more holistic view of risk through these expression profiles. What is our next step? Well, hopefully showing you the data are already translatable, that we have the power to do this. We need to really be thinking from a molecular standpoint, I believe, into how we stage and manage our patients forward and evolving our staging systems. So I show you kind of the two current staging systems that we use. On the left, the AJCC, or the tumor nodes and metastasis system, that predicts disease-related survival related to thyroid cancer. But equally important on the right, a second staging system, the ATA's initial risk stratification staging system, that predicts recurrence, an equally important endpoint in some manner. But neither of them in their current forms include molecular profiling or addition of those data. to the prognostic process, and they should. And I think we have the power and understanding to do so. And we should be moving that molecular expression analysis, I think, into the day-to-day understanding of care. You would think about someone very differently if you said they are a stage 1 AJCC, but a low risk ATA initial risk stratification grade, but it turns out they have a BRAF like genetic expression profile. That might tip you over to saying, perhaps we'll think differently about their treatment or their follow-up. Molecular understanding can independently, in an additive fashion, above histology and cytology and demographics, help predict survival and recurrence. It will guide our decisions forward. And are there other prognostic opportunities ahead? I think we're just starting the process here, and the answer is yes. I think you can imagine, what if we could identify a MEK signature that predicted iodine avidity? This is well within the reach of possibility ahead, because that would tell you responsiveness or not to perhaps radioiodine. It also would give you an opportunity, if they appeared not responsive, to consider a MEK inhibitor, which can at times augment that iodine uptake. What about identifying on cytology preoperatively a NIFT-P signature? Right now, there's no preoperative ability to identify accurately a NIFT-P, but this would be very important. Or a distant metastatic signature, or perhaps preoperatively an extremely low risk signature where maybe a non-operative approach would be valued. All of these appear likely to be possible in the near future ahead. And it really is just moving our mindset to acknowledge the prognostic thinking and the importance that these steps ahead would bring to the clinical environment. It's not just us, of course, and I think I like to show this slide because numerous other clinical arenas are using these types of prognostic genomic tests. They're actively in clinical use. If anything, I think our ability in the thyroid nodule, thyroid cancer world has been a little slow to kind of think in that form. They all use RNA expression, and they're proving very valuable. Perhaps the most famous you've heard of is the Oncotype DX story. But there are indications and supported Medicare-approved and paid tests in breast cancer, lung cancer, prostate cancer, melanoma, and you see them here. And so I think this really gives us also the support to take it forward in our field as well. So I'll come back to the outline I had listed and just reiterate a little bit. I think the past decade has been really a joy and exciting to follow, because molecular diagnostics have really proven the power of using genomic data to improve care, to harness and to showcase the value of an individualized approach where the right care can be given to the right patient at the right time, all for the overall better outcome it produces. But it's a long journey. It's not always an easy one to figure out, but as you can see, we clearly are moving ahead. My own belief is that the future here is that prognostic interpretation is equally a part of every diagnostic evaluation we do at the time of finding aspiration and nodule assessment, because we already have the ability to do this. So with my appreciation sincerely for taking time today to listen to this and join this great conference, I want to give you my conclusions as it relates to molecular prognostics and thyroid cancer. It's first to say that, as you hopefully have sensed, I believe the use of molecular data is improving thyroid care, but it is certainly complex. And I do believe all forms of genomic data hold actually great potential and power in different ways. But as you've heard me say, RNA expression is proving, in my opinion, to be the most impactful. Given its ability to analyze cellular pathways and processes, it also can iterate and constantly improve and find those patterns that are integrating thousands of units so that we understand something about that group, that pattern. As I told you, though, DNA mutations, while it's never all or none, I worry a lot that we don't overstep and assume that a mutation always means malignancy. It does not. And in fact, when we look at just single genetic mutations, oftentimes it's hard to find their independent additive power in addition to what we already know histologically. But certainly groupings of single gene mutations, maybe they will be helpful. Nonetheless, I think it probably is still substantially less than that power of RNA expression itself. We've historically used too blunt of an approach towards thyroid cancer care. I think we all believe that. And molecular data is really powerful as a prognostic tool. It is that individualizing process that I think will allow us to do this ahead. As a starting point, right in front of us right now, we can all begin to identify our thyroid cancers, our papillary carcinomas, as BRAF-like, as RAS-like, or as non-BRAF, non-RAS-like, 3 expression groupings that are validated prognostic tools already available for the day-to-day translation into clinical care, and they should impact some of our decisions downstream. These groupings, importantly, are independent of the other variables, which we're also going to use as well. And DNA mutations at times can supplement. That's especially true for that advanced disease. My opinion is that prognostic interpretation should now be a part of every diagnostic evaluation. That's how we should be thinking to provide the best outcome for our patients. There are certainly many questions left to answer. I've certainly proven that. And again, I just wanted to thank you for your attention, the opportunity to speak here to you today. And I'm certainly excited to take questions here upcoming. Thank you very much.